involved in organizing this interesting meeting, which I see as one more sign that system medicine is starting to take off in Norway. In my talk, I would like to discuss a couple of very exciting system medicine projects where I've been working, as I said, for the last years, together with people in University of Oslo and University hospitals. We are in personalized cancer medicine, one of them in breast cancer, the other one in leukemia. Probably many of you have heard about that. Cancer is a very heterogeneous disease. Heterogeneity is something to be worried about because it actually impacts treatment outcomes at many different levels. You can think in drugs for one patient, but not for others. Drugs that will kill some cancer cells for a patient, but not others. Or you could think, for instance, in a patient that metabolises a drug much faster than others. So heterogeneity is important, and it's a serious problem. On the other hand, we have a very large number of treatment possibilities. You can think in all the treatment modalities like surgery or radiation, all the possible drugs. But now think in all possible combinations of them. Think in all possible doses and schedules. You think it like that way, then the number of possibilities is huge. And actually, only a very few number of those have been tested in clinical trials. The problem with clinical trials is that, of course, we cannot do so many, and we cannot have cohorts that are large enough and homogeneous enough. So there will always be very little patients that benefit from the drugs that are tested. So not all these can be explored. So the evidence says that there's a clear need for personalization, but the problem is that there's no, due to the complexity of cancer, there's no straightforward way of doing it. So what are the possibilities in the systems medicine world to do personalized cancer medicine? We can think, for instance, now that we are in the times of big data and machine learning, we have heard already a lot about it. You can try to use some sort of black box statistical / computational model to be able to classify your patients. You can think, for instance, in clinical trial with many patients. So where some drugs are tested, and these sort of data-driven models will learn from the data what features, what patterns to classify patients into, for instance, responders or non-responders. And in the best case scenario, you will get a sort of uncertainty quantification, but you have some probabilities that the predictions are good. The problem with this type of black box classification or prediction is that the actual biology, the mechanisms, and the mechanisms and the dynamics of drug action are usually not taken into account at all. So even if we can make good predictions, we will not understand why the drug works or not. And even worse, we will not be able to say when it doesn't work what are the alternatives. So to a large extent, this approach is predicting without understanding. And a big problem of this is that you can only say things about drugs and dosage and things that have been tested in the clinical trials. So you cannot extrapolate. So if 2 pills have been tested in the clinical trial, I cannot ask my model what happens if I take one pill, or what happens if instead of every 6 weeks I take it every 3 weeks. So, in a way, or many will argue that this is not actually truly personalized medicine because of that, because I cannot just find the best possible option for each patient. I can only classify them according to existing. Many will also argue that this is actually not system biology, system medicine, this approach. I don't want to get, I guess it's a matter of definition, how you define it. I just want to show this because I want to make a difference what we do, which we think is more truly personalized medicine. We use mechanistic modeling and virtual treatment simulation. We use models that describe the mechanisms of action of the drugs, how the drugs are distributed over the tissue. And in this case, the personal clinical data are entered in very different ways into the models because they are informing in very precise ways aspects of the model, parameters of the model. I will talk a little bit more about how we do this. For a second, imagine that we have such a model, such a mechanistic model that describes the treatment response, and that by informing it with data from a patient, we can personalize it. So we can now run simulations to test different drugs, options, different doses, different schedules, even those that have never been tested in a clinical trial. So with the goal of finding what is the optimal treatment outcome for that particular patient. So let's see how we do this in our breast cancer project. This is histological slide from coordinated biopsy of one of the patients that we have analyzed. And here you see these pictures, you see where the cells are. So we are not looking here for features that could predict, like for instance, a deep learning method will try to do what feature will predict here what is important for predicting the treatment outcome. We are actually looking at where the cancer cells are, where the other cells are, how they are distributed, what is the densities. That's what matters for us, because we will use these distributions as the initial position. Here we will now simulate how the drug arrives to this tissue and how it acts in that tissue. We would also like to know for that where the blood vessels are, but unfortunately in these slides it was not available, so we were using MRI data, which are in a different scale. You can see cells, you can see single vessels, but you can look at the perfusion of the tumor, how well perfused the tumor is, and we were able to use that data to distribute vessels in that tissue so that they reproduce the perfusion that you see in that particular patient. So we have now cells and the vessels in that little tooth-like tissue, and what we want to do now is to model and simulate how the drugs are distributed in those blood vessels, how they extravasate from the vessels, how they reach the cells, and how they target so how they act on their targets. And for that we use a multi-scale model. We call it Pharmacokinetic and Pharmacodynamic model, where you see it's composed of different levels. We have this part here, intravascular module. There are equations that describe what is the concentration of the drugs in those patients. In a particular patient, we have also this extracellular module that describes other type of equations, how the drugs go out of the tissue and distribute in the cellular space. And then we have also some other molecules we model that are intracellular, that are associated to each of the cells, that in our case we model the cell cycle, so how fat cells proliferate, and we model also the expression of some of the molecules that are important because there are targets of one of the drugs that is taken here into account. Some of these processes that we model are extreme simplifications of reality. You need to do that. Some others are good approximations, I would say. And you always need to find a balance between reality and that the model is it's tractable and that you understand what you're putting in. The important thing here is that at all these levels, we were able to take data from clinical trials to inform parts of the model. And of course, not all parameters in these models will be taken from patient data. That's a limitation, there's a big limitation. That we try to get as much as possible from the literature, and we also did a calibration by using some of the patients. So developing a model like this is something that is very complicated and it takes time. I would say it took us about 3 years to do this. And you see all the details in this publication here. These are the 4 patients that we used to calibrate the model. There are from 2 arms of a clinical trial, and there are responders and non-responders. Here you see how this little piece of tissue evolves during the 12 weeks treatment. So now once you have calibrated the model, you can use it for making predictions. But I will not focus here so much. We have not also explored it so much in making predictions. I just want to show you that this type of modeling allows you to understand why therapy works and why not. And I will focus in one of the patients here, this non-responder patient that received a cocktail of chemotherapy and Avastin, which is an anti-angiogenic treatment that targets the vasculature of the tumor. So I'll show you one of the simulations of this patient. Here, this represents this cross-section of tissue. The black dots are cancer cells, the white dots are stroma cells, and in the background you see the oxygen concentration in that tissue. You see some red spots over there, which is the location of where the vessels are. So now we will simulate these 12 weeks of treatment. The treatment is given every 3 weeks. And you see how this evolves when the therapy comes. Some cells that are proliferating will die. But when the therapy is not active anymore, then some of the cells that have escaped the therapy will continue proliferating, and in the end, the therapy doesn't work. So by analyzing these type of simulations, you could figure out what is the problem, and you could figure out what solutions are possible. In this case, we thought, because it's a very slow proliferative tumor, and the therapy is given every 3 weeks, there's always cells that are not proliferating when the therapy is active, so they escape. So we hypothesize that given the therapy more often, but still the total amount is the same, so we give it now every week, we divide the dose by 3. Will work. We tried many others. This is the one we found it worked. Now you see that cells by 6 weeks will completely disappear. So this is just one example. We think this is a promising approach and a promising avenue to personalized cancer medicine, but obviously there's lots of things to do to bring this to the clinic. In some of them we have been working, like trying to extend these very little pieces of tissue to large. This is the scale of a biopsy, which is about 500 times bigger. Here we simulate millions of cells, and we can take into account more the heterogeneity in the tissue that is observed from the data. We're still thinking what's the best way to incorporate genomic heterogeneity into the model. We are thinking what will be possible clinical pipelines where this could be applicable. For instance, in this case, we're thinking we give the standard therapy for 3 weeks, then we measure, in this case, is the cell density in the tumor through MRIs. And we use that to estimate properly some of the key parameters in our model that we know, somebody mentioned it before, how the, when estimating those parameters, you have some uncertainty, how this uncertainty propagates through the predictions to make good predictions. So we're thinking in this, and want to mention this project was just granted, where some of these goals will be main objectives and main aims. It's a H2020 project that will start next year. It's coordinated by Professor Christensen that was supposed to be here today, but I think she has not. Correct. So I think it's very exciting to be part of this. In the last minutes, I would just like to briefly mention another project in leukemias, different type of leukemias, multiple myeloma and chronic lymphocytic leukemia, where we are trying to do the same thing. Things are a bit simpler because modeling number of cells in the blood is simpler than modeling a tumor with blood vessels. Things are a bit simpler. We want to do mechanistic modeling and evaluate treatment options as before. But here the data that we have are drug screening from patient samples. So in such drug screening, so you will get at some point in the development of tumor, you will get a sample of the blood of the patient that you can take ex vivo and try some drugs. Typically, you will get plot like this. Here in this axis, you see the concentration of the drug, and in this, you see the survival of these cells. But obviously, you don't know the composition of the sample. You don't know the existence of several clones or subpopulations. So we think that to make good predictions and to evaluate treatment options, before we would like to know, to use this data, to know what is the composition of the sample if we have several subpopulations and how each of the subpopulations responds to the different drugs that we've been testing. So how to do that? The idea is also using mathematical models and statistical inference. So we will use models that describe the evolution of the cells in a sample. In this case, we use continuous models. We have been testing several models, but a very simple one is to assume that each of the subpopulations in the sample will follow an exponential growth with a net growth rate that depends on the dosage of the drug. So if you don't have a drug, then you grow exponentially. If you have a bit of drug, then you have a bit of reduced growth. And this we encode it with this kind of function here. The parameters here will describe the response of that subpopulation to the drug. But we don't observe when we do this the subpopulations. So we have to sum them to get the total population. And now we can infer from this data, we can infer the parameters. By doing that, we will get this answer. So that's the idea. We assume there's an underlying model for each of the subpopulations. We put all of them together and then we feed to the data that we observe. Does it work? Let's see. How to test it? We've been using cells that we know are sensitive or resistant to particular drugs. So we know this is some cell lines that are resistant and sensitive to a lot of heat. And now what we can do is to mix them in different proportions. So we can mix them in 1:1, 50-50, 1:4, 4:1, and we do the test, and we get this. This information is confounded by the presence of different subpopulations. So what you see here is an average of all these things, how these different cells respond. So we can now apply our method to this data, but now we know the truth, right? So we can compare. And actually, the prediction of the model it's quite good. Like this is the mixture parameter. The truth it's the dotted line, and these are each of these experiments that we tested. Not only the mixture it's known, like whether it is 50-50 or 25-75, we also get right how each of them responds to the drug. This is the total response of each of the. So it works. And now the next step is obviously to test it with patient data, because those were cell lines. And now we have started doing this, and this will be part of another project, very exciting project, Digital Life, that is headed by Tasking Jory and Olaf Jessin, where we will be doing this with, we are already started doing it with CLL and patients, and use that information to simulate drugs and find their optimal treatment outcomes for them. As a mathematician, it's extremely exciting and a privilege to be part of such a project. And with this, I would just like to thank all the people involved in the different projects, breast cancer, leukemia, and mention the funding besides these two projects here. We have also funding from Big Insight, funded by the Research Council, and Percata Personalized Cancer Therapies, funded by the University of Oslo. Thank you so much.